Thank you, sir. Thank you
Thank
for
you,
the
sir.
nice
Please.
presentation. And also, the video demonstrated by T.S. Rao sir was also very clear, showing the anatomy of the nerve ducts, everything. It was very clear. And whenever we have the facilities like ICG, it's better to use it so that, like what sir has demonstrated, thoracic duct demonstration with ICG injection and also nebulization of ICG, demonstrating the tracheal this airway clearly. So better to have all those things so that whenever we are operating, the structures are clear. The injury chances will be less even unknowingly. So, so one question, if there are adhesions in the posterior mediastinum, where chances of thoracic duct injury are high, then would you prefer to ligate it or clip it and come out at the end of the surgery?
No, I think my indication for thoracic duct clipping is when the primary is actually involving the duct. Almost always, if you start dissecting between the duct and the lymph nodes, most of the time the lymph nodes just drop away from the duct proper because they are in a different plane, and generally they are not so advanced that they will be involving the duct. Even if there are lymph nodes around it, lymphadenectomy can be done while preserving the duct. Most of the time, it is involvement of the primary reaching the aorta or the esophagus, which is responsible for elective clipping of the thoracic duct, and we are not averse to clipping it at all. But routinely we don't do it. Elective clipping is important, and you should do it much lower than the tumor, and do it initially itself, so that the aortic plane also is clear. Because whenever thoracic duct is involved, the aortic plane has to be on the adventitia. You should not leave behind any tissue on the adventitia. So for all this, go low, dissect away from the tumor or the fibrosis, and then clip it electively. We are not against clipping it by necessity. We don't clip it by principle. We do it by necessity.
Excellent talk, Kalay, as usual.
Yeah,
This embolization of thoracic duct, is it being done anywhere? Who does it? How do they do it?
so there is actually...
It's a direct
there are
puncture and embolization.
No, they do it. There are two techniques. So the commonly for esophagus, since the leak is in the lower aspect, so the approach is from the dorsum of foot. So they do a lymphangiography, and then what they say is the step of doing lymphangiography itself, because the particles tend to block it, and thereby the leak settles down. We haven't used in thoracic duct, no personal experience, but actually we have one IR person who does it. So there are some cases where some of congenital chylothorax, so they have used even the axillary, the subclavian approach. So they from the neck, where at the entry side, so through that they cannulate the thoracic duct, go through the subclavian vein, then enter the thoracic duct and embolize. So both the techniques we have seen, but we don't use it as a primary intervention in our setting. But it is well described in the literature, and the studies are recommending it as the first, approach before.
Kalay, I've seen one lymph leak really stop. Injection into the groin node, lipoidal into the groin node.
Yes.
It's much easier than the web space lymphatic, because that requires much more experience, and the lymphatics are small. So you can actually inject into the node, and lipoidal does help. If you have a good radiologist, use him. If you are a good surgeon, don't bother about anything. Take the patient back into it. So it depends on where you are working, how good you are versus how good the radiologist is.
True.
Yeah.
Do you routinely document this RLN status, sir, before doing this thoracic surgery?
Yes, before and after also. And initially our paralysis rates were significant. serious actually, matching the international data. But truly we have improved so much, not just robotic but thoracoscopy also. The paresis rates have dropped significantly, so it's important to keep on doing. Important to keep on doing. FES is done on the 5th day, 6th day. Yes, it's a protocol and it happens.